So hi, my name is Ben Linas. I'm a doctor, I'm an infectious diseases doctor. I work at Boston Medical Center, which is in Boston. Clinically, my practice focuses on HIV and hepatitis C virus, and because of that, I have a lot of exposure also to opioid use disorders, and that's an interest of mine. My research all focuses on the comparative and cost effectiveness of interventions to address this endemic of HIV, Hep C, and substance use disorders, specifically OUD. So I do a lot of cost-effectiveness research, a lot of modeling work, and so it's a pleasure to give this lecture. It's an introduction to cost-effectiveness analysis and what it is. We'll touch a tiny bit on modeling methods, but not really. That's sort of a separate class. This is really sort of the core economic concepts of cost-effectiveness work. Oh yeah, wait, I forgot already. See, I'm having trouble. Good, okay. So the first question is, what is decision analysis? Because we really haven't gotten there yet today. So here's a couple of quotes from famous decision analysts over the years. One is that decision analysis is quantitative assessment of the outcomes that result from a set of choices in a specific clinical situation. Another quote, systematic, explicit, quantitative way of making decisions in healthcare that can lead to both enhanced communication about clinical controversies and better decisions. So these are two people who are not entirely independent of each other because they know each other well and one of them might have trained the other. But the big idea here, the core concept is that this is an approach or a branch of economics and of science that's focused on decision making, specifically for our purposes in healthcare. And that, when it sort of first came on the scene, was a rather revolutionary idea, that medical decision-making is not a magic black box, that it should be possible to look at the choices, and it should be possible to come up with some sort of rubric, even with its limitations, that would be able to help us make systematic and quantitative decisions, and really, most importantly, to shed some light on that decision process so we understand what's actually driving decision-making and what outcomes we're getting or not getting when we make those decisions. So when is a decision analysis appropriate? So first, it needs to focus the problem focus on a specific decision, right? So we really need to be able to articulate exactly what it is we're deciding about. It's not the vague decision of what should I do or what might be best. We really need to have a set of choices, right? We can do A versus B versus C, but not A and B, right? And that we also want to be pretty confident that there's not an option D that we haven't included on the list. Those choices have to be defined and well characterized, so it can't be something like do a little bit or do more. We need to have really well characterized interventions that we can ultimately quantify. There needs to be some uncertainty, of course, about the optimal clinical strategy. If it's slam dunk, already well known and standard of care that we must do A, it's probably not a great time to do a decision analysis because that decision's already been made for us. And the decisions need to have components that are not yet definitively available. So I think that's another way of sort of similarly, there needs to be some uncertainty about the optimal choice. So for example, there might be a couple of options for managing a condition, but you might be interested in what's the most appropriate for the subpopulation in which you're the most interested, right? And so you might have clinical trial data suggesting the overall efficacy of an intervention, but the decision analysis could help you decide, well, what aspects of this intervention should I apply to which subpopulations? And then another really important thing is there has to be a trade-off, right? Decision analysis requires comparison of competing strategies in which we can't do both. There needs to be some risk to doing this or potential cost with some potential benefits if we endure those costs or risks. And we want to see improved health for higher cost. So where people often forget this, I find, is when they're thinking about what might be best. And I can give a concrete example that happened last week where I was in a conversation with some folks about the benefits of associating medications for opioid use disorder with sort of cognitive behavioral therapies and sort of traditional addictions treatment. And one person wanted to say that, of course, we know that MOUDs are one component of a larger process that has to include some mental health components because of all the good reasons to include mental health with addictions treatment. And someone else said, right, but what if we can't do, what if we could give just MOUDs to many people, or we could give Cadillac MOUDs plus mental health services to fewer people? And the first person was having a hard time with that. That person really wanted to understandably link the MOUDs with cognitive therapy because no one wants to feel like they're just throwing pills at a problem. But my point was, look, if the real world choice was more MOUDs and more cognitive therapy and more everything for everyone, and that was possible, then that's the hands down obvious best solution. But what makes this tricky is that that's not actually on the table, right? There's a trade-off. We can either do more MOUDs for everyone or more of what I would call the Cadillac version of MOUDs for fewer. And that's the real trade-off that we have to concentrate on. If you get sucked into sort of a false situation where there is no trade-off, then you're missing the point of the decision analysis. I'm struggling with this. There we go. Applications of decision analysis. So the main application of decision analysis is to assist in clinical, well, one application, I should say, of decision analysis is to assist in decision making for a specific individual patient. Right? So there are people who do decision analyses where the end goal of the analysis is some sort of tool where if there is a patient sitting in front of me in the chair who's struggling with a decision between, say, surgical or medical management of a disease, we can help that person elicit his or her preferences, think about what's important to him or her, and then based on the decision analysis, provide one rubric for making the decision. There. Another thing we can do is to estimate optimal strategies for classes of patients with specific clinical characteristics in given situations. So, right, what's the expected public health benefit of meningococcal meningitis vaccination for HIV patients? Right, so we know this vaccine exists. There have been clinical trials saying that it's effective, but the decision analysis might drill down a little bit deeper to say what might be the benefits in this specific subgroup of HIV-infected individuals. Next. Where we often see decision analysis, and especially cost effectiveness being used, is for informing health policy questions, right? And that's really the sort of core of cost effectiveness analysis, where I'm going to spend most of my time talking today. And finally, the decision analysis can provide estimates of expected outcomes in situations where classical methods such as randomized trials are either impossible or impractical. So often we have a real-world question where there might be multiple clinical trials speaking to the efficacy of a given intervention, but really we know that those things are all functioning together as part of a larger package or over a longer time period that might be possible in a clinical trial. And so decision analysis provides a means to integrate all of those different data sources to come up with the real-world answer that we're really looking for. So, moving on, what is cost effectiveness? So cost effectiveness is really just one type of a decision analysis, but it's one that includes both costs and benefits in the decision-making rubric. So it's possible to do a decision analysis where the question is just, of these 3 diagnostic procedures, which one will diagnose the most cases? That's totally valid decision analysis. Cost-effectiveness analysis would take that one step further and say, I want to factor in both the number of cases that we're going to identify, but also the cost of the test and the cost of the downstream implications of that to give me some sense of what I should do, recognizing that there's costs in this equation, not just benefits. So the main focus of cost-effectiveness work analysis is value. If we invest limited resources, how much will we get back? Right? How will that compare to other things that we do every day? So this is something you're going to hear me come back to again and again throughout the hour. We're thinking about the economic concept of value, bang for the buck, or what are we getting for the money that we invest? And one really important thing to point out is that the goal of cost-effectiveness research is the same as the goal of all other public health research. It's to maximize public health. Right? You'll often hear people talking about, oh, you're not going to balance your budget on the back of my grandma, things like that. Right? We saw that with the ACA debates a while ago now. And there's this misconception that maybe cost effectiveness is looking to save money. We're going to come back to this point, but that's just not true. The fundamental purpose of cost effectiveness analysis is to maximize public health, just like all the research that everyone in the room does all the time. The only difference is that cost effectiveness analysis explicitly recognizes that it costs money to do that and that there's not an infinite pot of money available. And so the question becomes, well, given what we have available, what should we do, given that our main goal here is to spend that money and increase public health? Next slide. So there's a lot of misuses of the word cost effectiveness, and a lot of people who talk about cost effectiveness, but really they're talking about something that cost effectiveness is not. So the term cost effective is, right, and this is a quote that was from the New England Journal of Medicine, well, more than a few years back. The word cost-effective is rarely correctly used. You'll hear it surrounding almost anything related to money and healthcare. And that is absolutely true. I hope that once you come out of this 1 hour lecture and know more about cost effectiveness, you'll start listening, and when you hear reports on NPR or the news or wherever, there are smart people who know what cost effectiveness is, who routinely speak about it in the wrong way. Sometimes I think on purpose to make a political point, but often not. So the first major misconception of cost effectiveness, next slide please, is that when you say the word cost-effective, what you mean is cheap. Or even more common, that when you say cost-effective, what you really mean is saves money. Neither of those things is true. In fact, if you were only going to learn one thing all day today, well, I won't go that. If you're only going to learn one thing from this lecture, it would be this point. That when someone says something is cost-effective, if they're speaking about it correctly, that does not mean that it's inexpensive or cheap, and it does not mean that it saves money. In fact, almost nothing that we do saves money, right? Keeping people alive costs money, because the cheapest thing to do is allow people to die, because then they're free, right? But like I said at the beginning of or earlier in the lecture, our goal is not to save the money. Our goal is to spend all the money. We just want to do it in a way that helps people live the best, longest lives possible. So you'll often hear, this is the most common misconception. You hear it, speakers from CDC or wherever across the healthcare sort of sector will say, oh, we're going to vaccinate all these kids, and so we're going to save all this money because they're not going to get this terrible disease in the future. And that's true. You will save the money that they would have spent had they gotten the terrible disease, but the kids are going to now live for however many years, spending money the entire time, and it's a little bit grim, but one day they will get some other terrible disease, because one day we all do, and we're going to spend money on that. So we actually, with rare exception, do we actually save money by doing healthcare interventions. But that's okay, because the goal of our healthcare budget is not to save money. The goal of the healthcare budget is to provide health, and that's the goal of cost-effectiveness research too. Next slide. Right, so one more time, just because I said it, it is the most important point of the lecture. Cost-effective does not mean cost-saving. Next slide. So I've said this already, and I want to say it again. It's about cost-effectiveness is about value for money. Very few healthcare interventions save money, right? They usually cost more than they save, usually because people live longer, and then they start costing money. Right, we want to look at the comparative assessment of worth or value. And investments in health can be compared to evaluate competing claims on scarce resources, right? So the obvious thing is, should I do what I'm currently doing, or there's a new fancy technology that might be better than what I have now? And the question is, should I invest the resources to stop doing what we're doing now and instead do the newer, fancier thing, right? And the question is, well, depends on how much benefit you're going to get from the money that you're going to invest in the newer, fancier thing. And that's what cost effectiveness is really focused on. Next slide. So the next misconception is the most common misconception, I think, amongst people who do cost effectiveness research, which is to say that, well, if an intervention is cost effective, payers should be willing to pay for it, right? And I can't say about should, that's, should is a thornier question, but I can tell you objectively, just because it's cost effective does not mean that payers will pay for it. Because these are really two different questions, right? When you're talking about cost effectiveness, next slide please, we're thinking about value. But if you're a decision maker thinking about, for example, an insurance plan, you're not as concerned with value as you are concerned with, are we going to go bankrupt in the next year? Right? So if you are doing cost effectiveness research, your central question is, am I getting adequate value for the money that I'm investing in this new intervention? But if you're running a healthcare plan, your sort of existential question is, if we provide Hep C therapy to all the patients who need it this year, will we still be solvent come December? Right? Those are two very different questions. What they really have in common is they both at some level involve money. But other than that, they're really not a lot in common at all. So cost effectiveness analysis attempts to account for all the costs and the benefits, regardless of the payer or the beneficiary. So this has come up since I got here a little bit late, a couple of times already, the idea of the perspective. Cost effectiveness analysis assumes a perspective of society. We say, well, we're making social policy decisions, therefore we should be including all of the costs and all of the benefits into this analysis because everyone is being affected by this decision making. When you say something is cost effective from the societal or healthcare system perspective, that doesn't necessarily mean it's budget neutral to the payer, right? So if I'm a health insurer, I know that the cost of all the tests and the doctor's visits and the medicines and the hospitalizations that do or don't happen are all on my tab, and so those are important to me. However, quite frankly, the cost of the caregiver driving the patient to the office really, frankly, economically speaking, doesn't actually apply to me. And so from my perspective, that cost is not in the analysis because that's not my cost, right? So payers' analysis of the budgetary impact of a decision does not necessarily include all the same costs as a societal perspective cost effectiveness analysis. The other thing about cost effectiveness analysis is we conveniently don't talk about where the money should come from. All we say is, well, I don't know, just saying, right, if you do this, you'll get good value. And then we sort of walk away and say the rest is a political decision, right? We try not to do that, but when I start saying about what the political decision is, I feel like I'm changing hats away from cost effectiveness researcher into political actor / advocate. And where the money comes from is a pretty important question, especially if you're running the budget, right? So that's missing from cost effectiveness analysis and is important when you're thinking about budgetary impact. So that's for all those reasons. Insurers don't necessarily, of course, all things being equal, if they're going to do A or B and they know they're going to do something, they'd probably invest the money in the thing that provides better value. But there might be things that we say provide good value relative to the general healthcare system that are actually not really feasible or don't appear to be feasible from a payer's perspective. Next slide. And then the third most common cost effectiveness misconception is that cost effectiveness is the best way to make all resource allocation decisions. And that's not true. I will say that cost effectiveness, for those who did a little political philosophy in college, right, is an entirely 100% utilitarian approach. So our goal is to basically maximize the number of life years or maximize the number of QALY across a population, with total being completely agnostic to who gets those QALYs or why or when. Right? And so the classic utilitarian dilemma still exists, right? If we're in the lifeboat and we can toss my kid overboard and save 20 other people, the utilitarian approach would be to toss my kid overboard because it saves 20 at the cost of one. There's obviously a lot of ethical problems with that we could have an entire life discussing. And so it's important to keep that in mind, that we're making an absolutely 100% utilitarian assessment of what provides value and what doesn't. Next slide, please. And clearly, there are other things that matter in our decision making. There's concepts of clinical duty to take care of people, ethical duty to the person who's in front of you and the person who's not in front of you, equity or justice, right? A cost effectiveness approach would be perfectly happy giving all the money and all the healthcare to the majority dominant population in a society if that was going to help them live the longest and give the most QALYs, right? More sort of concrete and germane to this room, if you're thinking about substance use disorders and people with opioid use disorder, depending on what you assume about their quality of life, right? If the cost effectiveness approach might say it's not worth doing something for a substance user because that person's going to die anyway, or because that person's quality of life is so low that even by helping that person survive, we're not really gaining that many QALYs. Right? So I can come up with a lot of scenarios that are possible in a cost effectiveness analysis, and there's nothing within the cost effectiveness approach to prevent those outcomes. And so it's important to be aware of that and to recognize that just because it's cost effective does not mean we should do it. Patient preferences clearly matter. Economic efficiency in the sense really of the idea of cost, right, and budget do matter. If really the only goal is economic efficiency, then cost effectiveness probably is the right way to make the decision. Next slide. Okay. So with that bit of sort of thematic overview or conceptual overview, I want to walk through the steps of performing a cost effectiveness analysis. And again, this is not the steps for building a model in triage and solving it, although we will do some of that in the lab. These are the sort of conceptual steps that you would walk through as you begin thinking about a cost effectiveness analysis that you wish to perform. So the first step is going to be to define the set of possible intervention choices. The second step will be to identify the desired outcome or outcomes. Then we're going to identify the relevant constrained resources. We're going to identify the outcomes or the benefits and the resource needs or the costs for each intervention that we're considering. Then we're going to do the analysis, and what comes out the back, we're going to eliminate inefficient or so-called dominated choices. And then we're going to describe the trade-offs between the strategies that remain standing and we're going to define the value of those strategies using an incremental cost effectiveness ratio. So for the next bit of the talk, I'm going to walk through each of these steps bit by bit. Next slide, please. So step one is defining the set of possible choices. This might sound obvious that if I'm going to do a cost effectiveness analysis of approaches to managing opioid use disorder or hepatitis C virus, I need to know what the strategies are. And that's true, but really, we need to know what all the possible strategies are. It's critically important that all of the feasible strategies are in the analysis competing with each other. And likewise, it's equally important that nothing goes into that analysis that's totally not feasible and not really a real-world decision. Because ultimately, the choice of comparators in a cost-effectiveness analysis can be the most important driver of the cost-effectiveness conclusions. Right? So what we put into the space, an analytic space to compete with each other matters a lot. Next slide, please. And this is a sort of classic slide of decision analysis that you'll see in almost any lecture you get on cost-effectiveness or decision analysis. This was an article that came out in the New England Journal, I want to say in the 70s, right? It was back when the typeset still looked like this. The title was, what can we get from the sixth stool guaiac? Right? And this was a relatively straightforward cost effectiveness analysis where at that time people were doing, for those who don't know, stool guaiac cards or fecal occult blood testing. So you place a small sample of fecal material on this card, and then you put this blue solution on, or clear solution on it, and if the paper turns blue, it's a chemical reaction with the iron and hemoglobin, and it shows that there's microscopic bleeding in the stool, which could be a sign of colon cancer. So before we had colonoscopy and the things that we do today, we used these stool cards as a means of colon cancer screening. And at this point, people were doing 6 of them. Right? So the patient would go home and do 6 cards and send them all back in. And if any of the 6 was positive, that would prompt more of a workup for colon cancer. And so this analysis basically lined these up and said, okay, we can do, right, we don't have to do 6, right? It's possible to do 1 or 2 or 3, 4, 5, right? Or 6. And so look at the decision then and consider the value by estimating the cost effectiveness ratio in 2 different ways. The first way is the intuitive way, right? So here's the frame. These are the up to 6 stool guaiac cards. This is the number of cases of cancer that would be identified. Let's see if I can, there we go. This then is the total gain in terms of, the total cost, right? And the total cases identified. And so if you just say, I'm going to identify on average 71.9420 cases at a total cost of $176,331, right? Then you can come up with an average of $2,451 per case identified. I'm sorry, I got a little bit upside down, right? Really, you would say the cost over the number of cases identified, and that ratio would be the cost per case identified. And that makes a lot of intuitive sense. Right? It could easily be on a math test, and it would be the right answer. But if you think about it, right, that implies that, well, we can either do it or not do it. But that's not really the case. As I just said, what if we did 5, or what if we did 4, right? And so really, when you say I'm going to do the 6th card, you're not making a decision to do 6 cards or not do cards. You're actually implicitly making a decision to do 6 cards instead of 5. And when you do 5, you're saying do 5 instead of 4, et cetera. And so really, the better way to think about it, or the correct way to think about it, is at the margin. When we decide to do the 6th stool guaiac card, it's not should we do 6. It's should I spend whatever, a little bit more money for that 6th card, or should I spend the money on 5 cards and just do 5, right? And what will I get from that? And that's how we think, that's called the marginal cost, or the incremental cost, and the incremental benefit. And that's the way that economists think about this, right? If we're doing 5, really what we're investing is the cost of the 6th. And really what we're getting is the benefit of the 6th, right? It's not 6 versus 0. So when you do it that way, these are these incremental columns. So this is the incremental number of cases gained, and you can see the first card gets a whole bunch, right? Because the first card really is compared to 0. So doing any screening versus none, you find a whole bunch of cases. And already once you get to the second card, we're down to 5, right? And you can see by the time we get out to the 6th card, we are getting 0.0003 additional cases. And then the incremental cost now, right, looks smaller because it's certainly smaller than the total cost, right? It's an incremental cost of $13,190 for that 6th stool guaiac card. But when you do that ratio of $13,190 per 0.0003 cases identified, That turns into a cost effectiveness ratio of $47,107,214, which looks a lot different than 2,451. And we'll talk in a little bit about, well, what does that mean? Is that cost effective? Is that not? But you don't really need to have a line in the sand to label something as cost effective or not cost effective to understand that this number looks very different than that number, no matter what economy you live in and no matter how much you have to spend. Right, and so this is a point that if you had just looked at, should we do 6 dual guaiac cards or should we not screen for colon cancer, your conclusion would have been, yes, do 6. It looks beautiful. But that's the wrong decision, right? We're missing important options. And because we're missing important options, we're getting the qualitatively wrong answer. Next slide. Okay, so we said the first step was identifying all the options. The second step is identifying the outcomes. So cost effectiveness analysis is intended to inform broad allocation of resources and therefore needs correspondingly broad view of outcomes. There are different sectors of society. There are populations with different degrees of proximity to the intervention. And by proximity, I mean, well, I guess it could be geographic proximity, but generally what I mean is there's the population of people who will be directly impacted by the intervention, but there's that ring of caregivers around them who might also be impacted, et cetera. And so there might be more than just the direct patient population to consider. The consequences of an intervention differ at different time points, right? So when we say, should I screen for hepatitis C virus, yes or no, the obvious point to that is, well, there's the moment of screening, but the direct consequence of that is treatment, which is very expensive, so we'd obviously want to put that into the model. But then also, maybe a little bit less obvious, is there's also the consequences 10 years down the line or 30 years down the line from that screening, from that moment of screening, where the person starts to accumulate complications of liver disease or not, because that person was cured or not cured when we made the decision. So time matters. And the general, right, we could go, you could pull the string forever, right? At some, right, there's the person on whom the intervention applies, but that person has caregivers, and those caregivers have employment, and that job produces something, and you could keep on going. And so at some point, you have to draw a line somewhere. But basically, the rule of thumb is to start as comprehensively as you possibly can. So think big and brainstorm everything. Often we'll call that sort of a catalog or a list of all the benefits, and then you have to start to have a real, right, you might start to have to pare that down and limit it to a realistic subset of outcomes that you think are the most germane to the decision making, and frankly also the most germane to your reader or your audience. So there are times that there are outcomes that I think are fascinating that I recognize no one really cares, or at least not the people that the people who I really want to read this paper and change policy or change behavior just don't necessarily think that outcome is as cool as I think it is. And so you have to think a little bit about who your audience is and what are the most important outcomes. But when you're doing that, you want to choose a subset of outcomes that make some sense, right? And so that narrowed scope of outcomes should, sorry, it's the next slide. Yeah, thanks. Right, as I mentioned, reflect the choice of perspective of the analysis, right? So if we're assuming a health system perspective, and I want to be clear on some of this vocab, right? The societal perspective is everything. The health system perspective is what you generally, as a researcher in healthcare, what you generally think of as everything is actually the health system perspective, right? So the health system perspective is the doctor visits, the tests, the labs, the hospitalizations, the meds, all of those things. What it doesn't include is potentially lost labor time and things like that. So if we're assuming a health systems perspective, then outcomes should be important to the healthcare system. If we're assuming a societal perspective, then that outcome set might be a lot broader. Currently, there's recommendations on best practices for cost effectiveness research, which comes in a book that we sort of affectionately call the Gold Book. It's the Cost Effectiveness in Health and Medicine, second edition. And the current, a big sort of, in the world of cost effectiveness people, it was somewhat of an earth-shaking thing that the current guidance recommends that every cost effectiveness analysis includes at least 2 perspectives, both the health system perspective, which realistically is what we've all been doing all along, and the societal perspective, right? So that's actually, I don't know if it's double the work, but it's more, right? There are more outcomes to be had there because we need to be doing things from 2 different perspectives. And when you're thinking about the societal perspective, sometimes those outcomes are hard to measure, right? If it's things like lost productivity or extra time at home caring for a loved one and things like that, there are ways to measure those things, but you can imagine it's not as direct as years of life saved. And then ultimately, at the end of the day, your choices need to be subject to the rule of reason. So right there, like I said, you could pull on the string for every cost down to the penny and for every benefit out to the 6th degree of separation, but it would start to become not feasible and would stop your research, right? And it's absolutely, when doing this, possible to make the perfect the enemy of the good. And so when you're trying to decide where to draw the line, you need to recognize that the consequences, right, when consequences that are expected are so trivially small in the big context of the decision-making, it's probably not worth including. So a really good example of that might be something like, this comes up in our work all the time. If someone wants to do an analysis on the cost of the RNA test to confirm cure in the Hep C infected patient, which is ballpark $40 to $50, right? But the meds were something like $50,000, and the total lifetime cost, it gets up into the $200,000 or $300,000, and it's just not really realistic to think that that $15 cost on that, or whatever, that $50 cost on that second RNA is really driving the decision, and so probably we can let that one go, right? Because ultimately, all of these data are done with some form of modeling, be it explicitly a simulation model or a conceptual model that you sort of imply over an observed process. But at some point, we have to make some decisions about what matters and what doesn't. And when things are just so trivially small relative to the size of the whole decision, that's when you're justified in excluding them. But the caveat is you really need to be transparent about doing that, right? So make it clear what you do and do not include and why. Next slide. Okay, great. So we just talked about identifying the strategies and then identifying the benefits. So not surprisingly, the last piece of this, well, not the last of the whole process, but of identifying things, is identifying the costs that matter, or I should say the constrained resources, right? Because the obvious one is immediately to go to a dollar sign, because dollars are the way that we, right, can translate all resources into one common denominator such that we can swap them back and forth. But really what we're talking about when we talk about money is more the economic sense of cost, right? It's a fixed quantity of a resource. It could be livers for liver transplant or qualified personnel for HIV care, right? But usually we translate those things into dollars. That's the brilliance of currency, right? So healthcare, right, constrained resources like HIV care or HIV care providers in resource-limited settings, we can capture the idea of how hard it is to find those people by making them more and more expensive to hire. And so usually we translate constrained resources into dollars. Or I should say, it doesn't have to be dollars, it could be any currency, right? So if you're working in South Africa or in a resource-limited setting, absolutely it can be better and appropriate to describe your outcomes in terms of the currency of that country. And really that depends on the perspective you're taking. So the obvious one is currency for country, but there might be situations in which dollars make the findings more difficult to convey, and really you want to be thinking about in terms of successful transplants or something like that. Next slide. Great. Okay. So we've now sort of identified all the strategies and all the benefits and all of the costs. And now what we're going to do is sort of start to focus on the actual structure. And so we're not, like I said before, we're not really going to focus on the details of how to build a tree or how to do a Markov model, but I'll touch on those things a little bit, and you'll also talk about it a bit in the lab. So when you're first starting with decision analysis, decision trees are really the way to get started. A decision tree basically is a graphical way to represent a decision-making process, whereby we start at what's called a decision node at the very beginning, where the decision might be, how should I screen for hepatitis C in my methadone treatment program, right? And then off of that node, that's where I list all of my strategies, right? And we talked about how important it is to be sure that all the right strategies are coming off of the decision node, right? And from there, you walk through chronologically in a logical way to basically structure the entire decision-making process, right? So if the question is around screening for hepatitis C, with a given approach, say targeted testing for people who use drugs, you might walk through and say, fine, so the strategy is targeted testing for people who use drugs. The first thing that has to happen is the person who's doing the testing has to recognize that the person in front of them is a person who uses drugs, right? And that may or may not happen. Given that the person then recognized it, they may or may not offer the test. The patient may or may not accept the test. The test will be positive or not, right? And you can imagine, you walk it through. Each step is one sort of branch of this tree. You're trying to make branches that are yes, no, right? You can either walk left or walk right, right? And at the end of the day, you've walked all the way through the entire decision-making process. And at the end of that tree, you're going to assign some sort of a payoff, right? So if the person comes, they're targeted, they're tested, they get the result, they link to care, they're treated, they're cured, right? And you get to the end and you say, great, now I have a person who used to have Hep C, but now is cured, and that person on average will live for a certain number of years and cost a certain amount of money, right? And that's sort of the end of your decision tree. And so we're going to, the first step is to build that decision tree, right? Which is obviously not trivial. You have to think it through. And then the second step is to say, okay, now I have the structure of a tree. How am I going to fill that in, right? So to stick with our methadone maintenance example, right, we'll say, okay, the first step for a targeted testing strategy is that the person sitting there who's doing the testing has to recognize that the person sitting in front of them is actually qualified, is a high-risk person and should be screened. Right, and we need some data. Well, how likely is that to happen? Right, conditional on the fact that a person is a substance user. How likely is it for the healthcare provider who's going to screen them to recognize that and offer the test? Right, sometimes those data are hard to find, frankly, but that's the types of data you need to fill out the tree, and you need to fill out the probabilities or sort of the likelihoods for each step along the way. Then we need to assign some values to the outcomes. The easiest thing to do is, right, at least when we're talking about it, is to use life years, right? So if I have Hep C and I'm not cured, my life expectancy will be X. If I am cured, it will be X plus something else, right? And we can call the life years the outcome. But more commonly, as Sean was saying earlier, we use some integrated value, some value that integrates both quality and quantity of life. The most common one, well, yeah, I think it's the most common one. It's the one we use, is quality adjusted life years, right? There's this sort of competitor called the DALY, which is basically the same thing. They're sort of upside down from each other and they have differences, but both at their core are trying to integrate both the quality of life and the length of life left to come up with one number that we can put in a decision tree or a model. Then what we're going to do is we're going to use the tree to help us determine the expected value of each alternative. And expected value, I just want to look ahead for 1 minute. Well, so expected value, right, we're going to come, the tree is a graphical way to help us take, to estimate the expected value of a strategy. So expected value is a concept that helps with decision-making processes when we have imperfect information. So the place where expected value happens a lot is if you like to play poker. People who like to play poker, part of the reason they like it is because they like the strategy around the idea of expected value, right? And the idea is I have no idea what's going to come in this hand, but I do know that if I played 10,000 hands with these cards in this way, over the 10,000 times, right, I should start to get, my sort of variance should start to converge on the expected value, right? And so it's a way of saying, I can't tell you what's going to happen this time, but I can imagine an experiment where I repeat this process 100,000 times or 1,000,000 times. And when I do that, there's going to be variance and weird things are going to happen sometimes. But if I take the average, right, it's the central limit theorem. If I take the average of all those iterations of the same game over and over and over and over again, they're going to converge on the expected value. Right? That's how casinos make money hand over fist, because their expected value is always positive. So it doesn't matter how many people come in there and win $1 million because someone else is losing $1 million, right? And at the end of the day, they get the average, which is like whatever it is, a fraction of a penny per person times all of those people and all of that time, and it turns into big money. And then the last step of a decision, of a cost-effectiveness analysis, is to use sensitivity analyses to evaluate the uncertainty and test the conclusions. So frankly, often the best part of a cost-effectiveness analysis, at least a good one, it's the sensitivity analysis, even more than the base case finding of this is cost-effective or it's not cost-effective. Because sensitivity analyses are really the way that we can open up the hood and start looking under it, excuse me, and figure out what actually matters to this decision, what's driving this finding. And often it's not what people think it is. And so a good example of that is once when I was a fellow, we did a cost-effectiveness analysis of skin testing for latent tuberculosis infection in various populations in the US. And if you look at the literature about who to test and who to not test, it's very driven by the idea of toxicity, and that we shouldn't test all of these older people because they're more at risk of getting toxicity from the treatment, and so it's not safe. But if you do it formally and put it into a decision tree and do all the things that I said, and then you start to play around with the toxicity rate in the tree, it actually has absolutely no bearing whatsoever, right? You can cut it by a factor of 100, you can multiply it by a factor of 1,000, and it doesn't change the baseline conclusion, which coincidentally is that you shouldn't be testing those people, which is what the guidance says, except the guidance thinks it's all about toxicity, but it's not. It's because, right, frankly, those people are older and very few of them are actually gonna get tuberculosis before they pass. And so in that sense, it might not be worth screening, but it has nothing to do with the toxicity. And that's not the way that people were thinking about that decision. It was all about toxicity. So it's the sensitivity analysis that often can open the box and let you understand the decision, not just, right, the bottom line, that's cost effective, has little impact if you can't explain why. And the sensitivity analyses let you explain why. Okay, next slide. Terrific. So we're going to come back to this example that I've been touching on and was part of the lab before of hep C screening and linkage and methadone maintenance treatment. So current practice at most methadone programs is really not to do any testing for hepatitis C. Some do, but it's rare. And it usually relies on passive referral to hep C specialists for treatment and evaluation, right? So maybe your program will test you. But if they find that you're infected, they'll give you some sort of pamphlet and say you should go get treated. Or maybe they even have the name of a doctor who they've talked to in advance. But effectively, you're sent out to the world to go link to care. But as we were saying, there's been a 2-armed randomized controls trial of looking at different approaches to managing hep C in methadone treatment programs. And this trial had 2 arms. The trial had a control strategy, which was hep C screening and some education in 2 sessions, and then people were sent out to link to care. And then there's the intervention strategy, which was hep C screening and education for all patients. And then there was care coordination for the HCV infected patients, right? So there was a case manager who actively tried to link them to care. And then we, in our analysis, put in a hypothetical strategy, which is no intervention at all, right? So just, and right, in a real world study with people and human subjects concerns, that's probably not an ethical thing to do. Or certainly IRB didn't think so. But we can do whatever we want in a simulation model. So we'll often, because I said that it's the comparison that's really important, right? We like to have a hypothetical in there that is do nothing, right? But I will say that the hypothetical, notice that it says background testing, right? Well, we want a hypothetical that's still realistic. It might not be one that was in the trial, but we don't want it to be one that couldn't ever happen on Earth. And so it's important in the hypothetical no intervention to recognize that if we do nothing, it doesn't mean that no one's going to be tested for hepatitis C ever in their life. It just means no one's going to be tested at this methadone maintenance program, right? And there's something going on out there now. It might be less than we'd like, but it's not 0. And so it's important in the no intervention strategy to include the concept of the background, what we like to call the background screening rate, right? It's the counterfactual. If I don't screen you today for hepatitis C and methadone, what will happen? And there's some probability that you'll get screened tomorrow somewhere else. And so whenever we have the no intervention strategy, it always sort of includes or bakes into itself the idea of what will be happening if we don't do more. That's a common mistake I see when I review papers, especially screening papers. The strategies will be test or not test. And if you fall into the not test arm of the analysis, it assumes that you're never tested. Might be appropriate for some things if there's really no testing going on. But for many things, there is testing going on. Your real question is, should I test in addition to? And so it's important to include, right, whatever's happening now. So our goal is to identify and calculate the cost of hep C screening and education. These are the labs. And then right in lab 2, we're going to look at cost effectiveness and resources for linking hep C infected patients to care. We're not going to do the lab right now. We're going to walk through the concepts that you're going to employ in the lab. So this is going to take a societal perspective. Right? And so we're going to include both program and patient costs. So costs, right? The cost of the methadone maintenance program, things like direct patient-related costs like labor for helping people, the labor for paying the people who are running the program, the supplies of the program, clinic overhead costs, right? So it costs something to have the building there, and we want to account for some of that in the analysis. Of course, we want to include the downstream costs for hep C and for the HIV hep C co-infected HIV-related healthcare. So that's one step away from the actual intervention, which is the screening, though in this case it's a pretty obvious one that I think most people would immediately think of, that the next step is treatment. And so we have to have those costs there. And then I'm going to skip down the cost to the patient, right? That's what makes this really a societal perspective. If we were looking at only health sector perspective, we would say that the cost of the patients don't matter. But for us, right, we're thinking about the entire society, and so we are interested in cost of the patients. Bruce. Thank you. Appreciate that. So, sorry, I just lost my train of thought. Oh, right. So we're really doing societal costs, and we do want to think about things like cost to the patient, right, of getting to places and things like that. And again, as Sarah was saying before, what we're not going to include in this is the cost of the research itself, right, because that wouldn't be happening if we were in the real world. That's a hypothetical cost that's pertinent to the study, but not to the real world. And again, this was a study that was done using microcosting, meaning that somebody, like some of the people in this room, were there counting things with stopwatches and calculators and actually microcosting every component of the intervention. Next slide, please. Okay, so I said we're not going to talk about the model, but we'll touch on it a tiny bit. This is what these things start to look like, or at least a stylized version of them. This is all the decision tree. Okay, and then this is a Markov model. It's the Hep CE model. It's actually a Monte Carlo simulation that Sarah referred to. This could be overwhelming, but I want to give you guys some sense of like where these numbers come from. It's not magic, and if you start engaging with this, you'll start to learn how to do these analyses. So right here's the tree, and you can see this is the decision node, and then all the strategies are here, and man, I can't read them even from here, so I know you can't read them. But this is basically the control, like no intervention, right? And then this is the control. This is case management to link people who are Hep C mono-infected to Hep C care. And this is sort of a Cadillac intervention that's going to do both Hep C and HIV case management and linkage. In the tree here, these are the various steps of screening, right? So if this is the well, let's go down here. If this is the case management strategy for people who are Hep C mono-infected only, then basically we can say they can be identified or not identified, and then they can link to care or not link to care, and then they can start therapy or not start therapy, and then be cured or not be cured, right? And there's more steps. There's potentially more steps we could put in the tree, but that's the general concept. And then, okay, fine. If you think about it, when you do all that, the tree basically spits out the back end different categories of people. Right, so some people are Hep C infected and totally unidentified because they never got screened or they never came back for their test results or whatever it might be. Other people are Hep C identified, but they never linked to care. So they're walking around the world knowing that they're infected, but they're not actually in care. Some people go all the way to care and get cured. And then there's a fourth type of person who's rare, who goes all the way through treatment and does not get cured. And so really what the tree is doing is categorizing people, right? If I do this strategy, I'm going to have a certain percentage of the population will be cured and other people will be totally unidentified, right? And we can figure out, right, if those are the boxes, what percent of the cohort goes into each box. And then what all this craziness is basically a visual representation of how we figure out what it means to be a person with Hep C and cure. Right? How many QALY will you live and how much will it cost? And the way we do that is with a Markov model. The Markov model is beyond the scope of this lecture, but effectively it simulates the lifetime progression of the cohort as a series of transitions between health states, right? Each of these circles represents a health state. The most basic Markov model has 3 health states. You can be well, you can be sick, or you could be dead. And if we say, okay, we're going to define a time cycle for our model, like 1 year, and if everyone starts the model well, every year they have some possibility of moving to becoming sick, right? And if they don't do that, they stay well. And every year they also have some probability of moving from either well or sick to being dead, right? And you'd think that probably the likelihood of moving from sick to dead is higher than the probability of moving from well to dead. And so by doing that, we just advance the clock over and over and over again and count where people are in every month. Right? And if we just count up the number of months that were spent in alive or sick, that's life expectancy. Right? We could attach QALY weights to being alive, to being well, or to being sick, and if we had those things up, that's quality adjusted life expectancy, or QALYs. And if we take a price tag and stick it on each of those health states, we can also sum up the costs. And effectively, right, that gives us some estimate of lifetime cost and lifetime benefit. Those are the outcomes we need for cost effectiveness. Obviously, the real models have more health states and more sort of tricks and things like that, but at their core, that's really all they are. It's just walking people through life in a probabilistic way and counting up what happens. And by doing that, we can say, here's what the life expectancy is for a person with hep C that's cured. Here's life expectancy for a person with hep C that's not identified, et cetera. Okay, next slide, please. See, this is where I got tripped up before. I knew this slide was coming, but I forgot where. Like, what is expected value? I touched on it already. For the sake of time, I won't do it again. But right, that's what our tree is going to give us. It's going to take the weighted average of all those probabilities and all of those payoffs and come back and tell us the expected value of the strategy if you did it for a very huge number of people. Next slide. And this is the sort of meat of what we're going to get to now. This is what you get out of that, right? This is a cost effectiveness table with no annotation and nothing else in it, right? So each row is a strategy. Then here we have the cost, right? This is the discounted lifetime medical cost of the population. And this is the quality adjusted life years lived by that population. Notice this is a small number of quality adjusted life years because that might depend on how old the population is going in and what their competing risks of death are. So we're going to use this table now to start thinking about how to generate incremental cost effectiveness ratios. Next slide. Okay, so this is sort of the Wizard of Oz moment where you look behind the curtain and realize that cost effectiveness is actually not that complicated, right? Because this is the cost effectiveness ratio and how you generate it. It's just the cost of option B minus the cost of option A, right? That's the incremental cost of option B, divided by, right, the benefits of B minus the benefits of A. Right, this is the incremental cost and the incremental benefit, or QALY, right? And that ratio of incremental cost to incremental benefit is the incremental cost effectiveness ratio. And I keep saying incremental over and over again on purpose because just simply taking cost divided by life expectancy or cost divided by QALY really has no value at all, no interpretation at all. It seems like that would be the cost effectiveness ratio, but it's not, because the question is always in comparison to what? You can't generate a cost effectiveness ratio without a comparison. So always ask yourself, compared to what, compared to what? Next slide. So then what do we do with that number, right? The most common error, and after lecture usually, hopefully I can prevent it, before I put this slide in, when I gave a talk like this, often the most common question was, I don't get it, why don't we go to the table, find the intervention that has the lowest incremental cost effectiveness ratio, right? Because that's what's giving us the most, like that's what's giving us a QALY for the least amount of money, right? And that's what we should do. But the issue is, if you look at the table, can you go back up actually 2 slides? That one, right? So if you look at this table, as we go down the table, we're actually getting more quality adjusted life expectancy, right? So the intervention that has the lowest ICER does give you the lowest cost per QALYs gained, but it also often gives you less total life expectancy than some other option which might have a higher cost per QALY gained, but give us more QALYs. Right? And our goal is not to, right, as I said at the beginning, our goal is not to save the money, it's to spend the money. So we actually want to do the thing that gives us the most number of QALY with the highest ICER that we can actually afford. Right? We're going to come back to thinking about how to make that decision. But you don't just want to race to the bottom, because that would be the way to save money. If you go that way, that's a slippery slope, because I can go one better, do nothing, and you'll spend nothing. So our goal is not to choose the lowest ICER. It's to choose the greatest life expectancy that we can actually afford in our healthcare system. Afford might be the wrong word. That provide the greatest life expectancy that we would deem as cost effective. And we're going to come back to that in 1 minute. So skipping down back to the how do we interpret ICERS. Yeah, thank you. So what we're going to do is we're going to look at this ICER table, right? And like I said, the strategy with the lowest ICER typically also has the lowest benefit, and we want to maximize benefit. So really, we're going to go up to the highest ICER that falls under our line for cost effectiveness. And our proxy for that line or for budget is a willingness to pay threshold to save 1 year of life. Next slide. So before we do that, like, theoretically, what we'd really like to do is if we had an ICER table that had every single possible intervention in healthcare, with its costs and its outcomes. Then what we could do is actually optimize every penny that we spend, right? Because we could take this sort of theoretical Uber list and we could line the whole thing up, and then we could start at the thing that gives us the lowest cost per QALY gained and fund that to 100% until everyone is helped by that and we still have money in our pocket. Then we'd move down the list and do the next thing, and we'd keep on going until we ran out of the entire budget. And by doing that, we would have maximized or optimized our resource allocation. Right, but that's obviously not really possible. We can't possibly have a list of everything that we ever do in the healthcare system, so we need some other approach to thinking about that. And so, gosh, this slide was made on the airplane. I apologize for the typo. The practical approach is to try to estimate the average, right, in quotes, benefit that we would get by investing $1 more into our healthcare system as it stands now. Right? Because if we did that, then anything we can do that gives us better than average return for our dollar is a good thing to do, and we should probably do that, and we would say that's cost effective. Right? And our best proxy for that average return is called willingness to pay. Unfortunately, willingness to pay was a terrible misnomer that's like an albatross around the neck of cost effectiveness, because it has absolutely nothing to do, well, I would argue it has absolutely nothing to do with a willingness to pay. It's not meant to be a moral judgment or any sort of estimate of how much a year of life is worth. You could interpret it that way, I suppose, but you don't have to. Right? Really what it is, it's about opportunity cost. And Sean touched on this before. Willingness to pay is meant to represent the idea of we're doing something already. Right? And because we can't make the Uber list, we're going to say on average we're getting something for $1 in the US healthcare system. That's going to be our willingness to pay threshold. And if we're getting better value than our threshold willingness to pay, right, then we should invest in that opportunity, because using the resources on that would provide more QALY than we're getting on average now. Right? Another reasonable way to think about it is, given that we routinely provide intervention X in the US and our new technology provides better value than X, then we should also provide our new technology. Right, so actually, there are no moral judgments here. There's no estimate of a willingness to pay for anything. You don't have to think of this as the value of a human life or a year of life. Right? Really, it's just about opportunity cost. Right, and so what is that? What is our willingness to pay? What is the opportunity cost? So these are some ICERS of interventions that we typically employ every single day in America. Some of them are a little old now. And I should say, right, to make this slide complete, I should say compared to what? Right? I just spent a lot of time saying it has to be compared to something. And the compared to what are not here. But to give a sense, right, propranolol for mild hypertension, thrombolytic therapy for an acute MI, right? And then you get to dialysis and end-stage renal disease at $51,000 per QALY gained. So some people may have heard this ICER of $50,000 per QALY gained is the threshold of willingness to pay in the US. That's where this comes from. Right? It comes from the ICER of dialysis, and because dialysis is baked into the Medicare legislation, it was taken as sort of a reasonable proxy for willingness to pay in America. But keep on going, right? Dialysis in seriously ill adults, which I guarantee is happening in every ICU in America right this very minute, has an ICER of $147,000 per QALY gained. So there's some sense here that actually it's not clear what our willingness to pay is or what our sort of average return is. Next slide, please. And that's absolutely true, right? Even since 1982, people have cited this $50,000 per QALY as a willingness to pay threshold. But just by simple inflation alone, $50,000 in 1982 dollars or $164,000 in 2010 US dollars. So just by inflation, which really is just, inflation's important, but it doesn't actually sort of point to any change in the value of in what we're doing in healthcare or in our average return. It's just like the nominal value of $1 is already up to $164,000. So anyone who's been saying $50,000 per QALY really should be saying $164,000 per QALY. There's also many examples in the US where we pay more than $50,000 per QALY and perceive this as being a good value. So in general, in our work, we've sort of moved to using the $100,000 per QALY as our sort of threshold for willingness to pay, but that's totally arbitrary too. And so there are decision analysts and cost effectiveness people who would say that what you should do is just provide the ICER and perhaps contextualize it relative to other things that people recognize and say are good or bad things to do, and allow the reader to make his or her own judgment. I personally think that putting that label of cost-effective or not cost-effective is helpful to generate discussion and move the debate forward, but that's an open sort of field of discussion. And remember, we're going to choose the option with the greatest benefit that has an ICER that's below our willingness to pay threshold. So now we talked a little bit about eliminating dominated strategies as the next step in the process. So this sort of 2x2 space, other people may have seen before. The axes in this space, oh, sorry, next slide. Yeah, great, thank you. So the axes in this slide are across the horizontal axis cost and across the vertical axis healthcare outcomes, right? And so we're going to look at these two corners first. Anything that actually saves money and improves health is what's called a dominating or dominant strategy, and clearly we should do that by any sort of rational approach. If we can both save money and improve outcomes, that's a good thing to do, and we shouldn't really have to debate that. The same thing, anything that we're spending money on and getting worse outcomes is something we clearly should not do, right? Because we're just burning money. You'd be surprised, though. We do many things that are actually dominated strategies, right? And then where most of the action is in these extra spots, right? And where we usually find ourselves is here, things that cost money and improve health. And then the question is it worth it? Is there enough value? But what we really want to try to do is make sure that we eliminate from consideration in our cost effectiveness table all of these dominated strategies, right? Because those are not rational. We shouldn't do them. So there's actually two different types of dominated strategies. Next slide, thanks. Two types of dominated strategies. The first one is called strict or absolute dominance. It's the easiest one to wrap your head around. So imagine, this looks like the cost effectiveness table from earlier, but it's a little bit different. The numbers are different. So imagine that it looked like this, right? And notice this red number here, right? This is a strategy that costs $138,800 for 6.4 QALYs of average life expectancy, compared to here where it's $129,300 for 6.912 QALY. So this is a strategy that literally costs more money and provides less benefit. That's an absolutely dominated or strict dominated strategy, and we don't want to do that. Next slide. If we try to make an ICER, right, if we try to come up with the incrementals, we get this negative 0.512. So what do we do with that, right? And I put the question marks are there. Do we have a negative ICER? It's hard to interpret because it's irrational, right? And so really what we want to do, next slide, is just cross it out entirely, right? It's not something we should be considering. It should be eliminated from the decision space. And then we need to go back, next slide. Oh, sorry, I'm wrong, just keep it right there. Can you go back up one? Thanks. Right, and then what we need to do is eliminate this entirely, and then we need to recalculate our ICERs by doing 145,300 minus 129,300, right? This is the incremental now, because this one doesn't exist for us. This strategy is dead to us, gone. We're gonna ignore it entirely and can make this comparison and recalculate all the ICERs, right? So that's eliminating the strictly dominated strategies. Then there's the concept of extended dominance, which I have to say, dominated is like a binary outcome. You either are dominated or not dominated, not you, a strategy. Right? So to say that, and when you say strong or strict versus weak or extended, it makes it sound as if one type of dominance is stronger or better or more important than the other. And in reality, that's not true. Both are irrational, both are a waste of resources, both should be eliminated from the decision space. They're just slightly different mechanisms, right? So this is the mechanism of extended dominance, right? In general, dominated strategies are strategies that cost more but provide less. But what about two strategies that both do provide life expectancy and both add cost? So that's where we usually see ourselves. But one gives additional, like even better life expectancy, and it does that at a lower cost per life year saved or per QALY saved, right? So you're basically getting more, and you might be spending more, but you're actually spending less per unit, right? And so that's sort of like buying a value pack at the grocery store, is the analogy that I like to draw, right? And so if you know, granted, right, at some point it breaks down because they're gonna go rotten in your fridge, but assuming you're gonna eat them all, right, then you're better off buying the larger pack of chicken breasts or whatever it is you're buying because you're getting more at a lower cost per unit purchased. And so that's a dominating strategy. What it looks like in a cost effectiveness table when you start getting extended dominated strategies is that here we have all the strategies lined up in order of cost, right? So here they are from lowest to highest. And when we look here, right, we see that the QALYs also go up in terms of lowest to highest. So that's our first signal that we don't have any strictly dominated strategies, right? If we had this one being lower than this one, costing more but less benefit, then that would be a strong dominated strategy, and we would see that right away. This one, you can't see the dominatedness yet, right? Everything looks kosher so far. Costs are going up, QALYs are going up. But then we start to do our incrementals. Next slide. Right, and so here we have the incremental costs and the incremental QALYs, right? And then we start to do the incremental cost effectiveness ratios, which is just incremental cost divided by incremental QALY, and here they are, right? And then we see, this incremental cost effectiveness ratio is higher than this one, which is sort of hard to wrap your head around, because why would I want to spend $26,989 per QALY gained and get an incremental 0.352 QALYs, when instead I could spend $21,595 per QALY gained, and relative to this strategy, right, gain even more. Right, so I'm actually spending more per QALY to do the other strategy and getting fewer. I don't like that. I'm going to do the thing that gives me more QALYs at a lower cost per QALY, and that's exactly right. So next slide. Right, this strategy is dead to us too. We're going to eliminate it entirely for the exact same reasons as we eliminated the extended dominated one, because we're getting less and paying more, and we don't want to do that. And then we're going to go back through and calculate all the ICERs again. Right, so that's the one, mechanistically, the way to find the extended dominated is you make your table. You know what? I didn't say this, and I should have earlier. You make your table and order the strategy in terms of ascending cost. Right? And then you look and make sure that you don't have any that when you put them in ascending cost, if one of them is giving less life expectancy than the strategy above it, that's a strong dominated strategy, and you can eliminate that right away. Then you start making cost effectiveness ratios, and whenever you see a non-monotonic relationship, can you go back one slide, please? Right, when you see this non-monotonic relationship where it goes, where this was higher than this, that should tip off that there's an extended dominated strategy. And so you start to eliminate those, and you recalculate all your ICERs again. And it's pretty common if you have many strategies in an analysis that many of them are actually dominated, and sometimes you'll start to get this cascading dominoes effect where you eliminate a dominated strategy, which reveals that the next strategy is also dominated, right? And as you start to eliminate and recalculate, you end up with a small number of strategies that are not dominated. Sometimes. Okay, getting close to the end. There's another way entirely of thinking about ICERs where everything that I told you is still totally true. It's just a slightly different way of doing the end calculation, right? So all of our ideas about value and willingness to pay and everything that I said remains true. But instead of generating an incremental cost effectiveness ratio, which gives us the cost per QALY gained of an intervention, we're going to express that in terms of net monetary benefit. And really, net monetary benefit is what it sounds like. It's the total benefit of a strategy, which we're going to monetize, minus the total cost of that strategy, right? And so things that give us a lot, right, have a big total benefit, and don't cost very much have large net monetary benefits, and vice versa. Things that give us little but have a lot of cost have low net monetary benefits. And things that have negative net monetary benefit are dominated, and we should get rid of them. So the challenge here is how do we monetize the benefit, right? If the benefits and QALYs, how do we monetize that? And then people get a little bit uncomfortable because it seems weird to monetize a life. So an economist would say, get over it. We do that all the time. But you don't have to do that. We can have that conversation, but you don't even have to go to that space in order to do this approach. Because we already talked about the idea of a willingness to pay threshold and the opportunity cost, and that really what this is representing is the sort of average that we get for $1. So really what we're doing is we're now saying, we've sort of turned this into a currency, right? If I have $1, I can invest it in the healthcare system and get a certain number or fraction of QALY. And theoretically, I could instead give those QALY back and take the money out and use it for something else, right? So really what we're saying is, right, if the willingness to pay threshold is $100,000 per QALY, we're effectively saying we can trade $100,000 for a QALY or trade a QALY for $100,000. And so then what we can say is, great, now we can monetize, right? Each QALY is worth $100,000. So I can use my model, come up with an average life expectancy or quality adjusted life expectancy. Each one of those, each QALY gained is worth $100,000, right? So now I can multiply QALYs times 100,000 and I have a dollar figure. And it's easy to then subtract, right? The cost is a lot easier to deal with, right? The cost is the cost. So I monetize the benefit, subtract away the cost, and what's left is the net monetary benefit. It can be helpful if you start working in triage. Triage automatically, in all of its sensitivity analyses that it does for you, it uses net monetary benefit. The reason why is it's because it's convenient, because actually it's linear and you can deal with negative numbers. Afterwards, if you're interested, we can talk about it. But when you start dealing with dominated strategies, they don't converge. So as things get closer to zero, one goes to positive infinity and one goes to negative infinity, and the graph looks crazy and it's not interpretable. Whereas net monetary benefits can be linear and they're easier to work with. Okay, so here it is. This is just the results with net monetary benefit. We have cost, we have QALY, here's the monetized benefit, right, which is just this times $100,000, and here's the net monetary benefit. And what you can see if you go back through the slides or compare, the ordering in net monetary benefit is the exact same as the ordering in ICERS. So alternatives to willingness to pay is worth thinking about for sure. Like, willingness to pay is the most challenging part of cost effectiveness work, because you have to either say that it's some sort of moral judgment and that you're willing to put your flag down that a year of life is worth $100,000, which makes most people uncomfortable, or you have to buy into this idea of the average, which kind of theoretically is easier, but it's hard to prove that the average value of $100,000 in American healthcare is one QALY. But it does and also, right, it gives no guidance on how to prioritize among the interventions that have ICERS that are less than a willingness to pay. So one of the challenges to cost effectiveness research is we all do it in the fields that are important to us, and then come forward and I say things like it's absolutely cost effective to test and treat everyone for hepatitis C and to take care of people with opioid use disorder and all of these things, but there's someone else who's equally passionate about breast cancer who would say the exact same thing about breast cancer interventions. And so how do you then prioritize, right? The willingness to pay rubric doesn't really let us do that. Also, in reality, like, this is not really how policymakers think. Right? Policymakers tend to think on short time horizons, and they tend to think about budget with some element of benefit. Everyone understands the idea that they want to get something for the money, but usually not in a highly formalized and rigorous sort of structure like willingness to pay. Further, as I pointed out, the threshold really is somewhat arbitrary, and the only debate I think we could have with that is whether it's somewhat arbitrary or fully arbitrary, and is a stylized representation of a resource constraint. So, that's sort of the holy grail of cost effectiveness research. What are other ways to think about value and other ways to categorize strategies as either cost effective or not? Because at some point it has to be interpretable, right? Just providing the numbers is not very helpful if you offer no structure for how to interpret them and how to make a conclusion. Because really we are trying to make decisions like, we're going to do this or we're not going to do this. And so thinking about that as you work through your cost effectiveness work and reading will be useful. Okay. Briefly, the last step in all cost effectiveness is sensitivity analyses, the way that as I was saying before, we can't just show the ICER, right? We need to show people under the hood. We need to help people understand why we reach the base case conclusion, understand the factors that are driving our conclusion, and then we'd also like to know how robust the findings are to uncertainty and the parameters that went into the model. And sensitivity analysis can do all those things. Next slide. The first thing we usually do is what's called a one-way deterministic sensitivity analysis, which is really sort of the most straightforward and easiest to think about. We're going to choose a model, right, an input parameter in that tree or that Markov model that we think is important. We're going to systematically range it through its feasible range from low to high, and we're going to observe what happens to the conclusions when we do that. So, right, how do our conclusions about, this is an old slide, we never talked about total corpitis in this talk, right? How does our conclusion about the condition testing methadone maintenance change as the prevalence of the disease changes, right? And I put on here that you should have a hypothesis whenever you do a sensitivity analysis. You need to do a lot of them and you're going to tee them all up, but it's good before you start to interpret them to say, what would I expect, right? So if the question is screening for hepatitis C virus and the sensitivity analysis is on prevalence, my hypothesis going into that analysis is the more prevalent hepatitis C becomes, the lower the incremental cost effectiveness ratio should be of offering hepatitis C screening, right? That's a pretty straightforward one. Sometimes it's a lot more complex than that, and you have to really think. But it's a really good idea to start reviewing those data with a directionality in mind. Because that way, when it doesn't match up with what you thought, you can figure out, there's a problem with my model, or maybe there's a problem with the way you were thinking about it. But that's actually, when you're gonna have a eureka moment in cost effectiveness analysis, it's this. It's the one-way sensitivity analyses, or maybe two ways, which we'll talk about, where you start to see insights that you never had before. And a good question to ask is, what are the threshold values are very meaningful for analysis and certainly for papers, right? So this is the classic. The cost, we've been doing a lot of work on hep C screening with CDC. The question they're always dying to know is, what's the prevalence threshold, right? At what prevalence of hepatitis C is screening cost effective? And then we try to explain how it's more complicated than that, and there's subgroup, but basically what they want to know is thresholds, because that's what helps people make policy, right? Thresholds become more generalizable and easier to talk about, and to say, well, the prevalence there is above threshold, therefore it's cost effective. Two-way sensitivity analyses are really the exact same thing, except now we have two variables that we're going to vary. And there's nothing magic about it. The computer just does it with brute force. You take variable 1 and hold it at one value, and take variable 2 and range it, right? And then you move to the next value for variable 1 and range variable 2 again. And so if you have like 10 levels of variable 1 and 10 levels of variable 2, the computer is just going to do 100 simulations and then plot the outcomes for you. And when it does that, next slide, it looks like this. So this is a representation of a two-way sensitivity analysis. On the vertical axis in this one is the additional cost of the intervention compared to control. And on the horizontal axis is the probability of linking to hep C care among patients with chronic mono hep C infection in the intervention strategy in our methadone maintenance program. And the way you read these is to go and find a spot on the horizontal axis that represents a linkage rate, right? And a spot on the vertical axis, a point that represents a cost of the intervention. And the intersection of those 2 points, you then look at the color and come over here, and it tells you at a willingness to pay threshold of $100,000 per QALY gained, which was the preferred option, right? And the preferred option was the one that gave the highest quality adjusted life expectancy with an ICER that was lower than $100,000 per QALY gained. And right, this dot represents the base case of that analysis, and so in this analysis, right, the base case conclusion was that you should do the intervention. However, as you might suspect, if the linkage rates really fall to terrible, then the intervention stops looking so good, right? And now we're into this space, which is control. Likewise, if the intervention becomes super expensive, right, then probably what we should do is limit the number of people who are getting that intervention and only focus on the people with hep C mono infection, right? Whereas this is all people, including co-infection. And so again, it's good, right? If you think about it, if you fix one of these and just go up, or fix here and go across, you're basically doing a one-way sensitivity analysis, right? But this lets us look at both at the same time. These I find to be very helpful. Often you can find 2 things that really drive a lot of the analysis. So a common one for hep C things would be the prevalence of hep C and the incidence of hep C amongst drug users, or something like that. So the base case, when we go, right, think back when I went through all the steps and we built the model, and then I said we have to populate it with the probabilities that go into the various branches. So the base case is our best estimate of everything, right? So we're going to go, if there's 150 parameters in our model, we're going to hit the data or the literature or whatever, our various data sources, and we're going to come up with an estimate of every single parameter in the model. And our base case is what we think is our best guess at all of them based on the literature, right? And so that's sort of our nickel down saying we think the answer is X. However, we recognize there were 150 parameters that went into that, so we're going to explore them in these sensitivity analyses. So sorry about that. Base case is sort of cost effectiveness modeling jargon for best estimate. And then finally, right, these are all deterministic sensitivity analyses, which can show us a bit about the robustness of the conclusions to uncertainty in those 150 parameters. But in reality, we're only doing one or two at a time, right? They're more helpful for looking at the impact that a given parameter has on the findings. If we're really interested in uncertainty analysis, then we can look to probabilistic sensitivity analysis. So probabilistic sensitivity analysis, right, is a way to consider simultaneous uncertainty in every model parameter or a large subset of model parameters to develop some quantitative estimate of how certain we are in our conclusions, right? And so I would never use the word confidence interval around a probabilistic sensitivity analysis, right? Because when you start using the jargon of confidence intervals, you're implying a whole lot of probability theory and parametric assumptions that absolutely do not exist in a simulation model, right? But to the extent that it is the simulation modeling attempt to provide some kind of gauge of confidence, it's similar to the role that a confidence interval plays in statistics. And the general idea is that we're going to say, fine, we have an estimate for what every value in this model is. That's our base case. But in reality, there's uncertainty around that, right? There's uncertainty related to just sort of the variance in clinical trials. There's also like real, like parameter uncertainty to the fact that just because study A found the parameter with some value doesn't mean that that is the value for all people everywhere, or that they wouldn't have found a different value if they did it a second time, et cetera. And so what we're going to do is we're going to develop a distribution or a probability density function around every single input value, right? So it might be things like, I don't know, the prevalence of hep C in this group is about 25%, but I don't know that for sure, right? I think it's 25% with a 95% confidence interval around it. And there I really mean it, like a real confidence interval. And I think the incidence of hep C in drug users is something, but there's some range for that, right? And I think the prevalence of opioid use disorder is this or that, or the overdose, whatever it is, right? We deal with uncertainty all the time in biostatistics. So we're going to define those distributions around every model parameter. Then we're going to do our simulation n number of times, 10,000, 100,000 times. Each time, the model's going to go and it's going to draw, right, a value from our probability density functions and plug those into the model and run it and log the outcomes. And we're going to do that, like I said, 10,000 times, each time drawing a different value, right? And when we're done with that, we're going to end up with 10,000 different ICERs, where each ICER reflects a different combination of inputs, right, with the simultaneous uncertainty of every input in the model. And then the question is, okay, great, so how do we display those results? So the classic way to do that is what is called a cost-effectiveness acceptability curve, or a CAC, which is the recommended way to do it. There are others, but this is the one that the Gold Book recommends. So in a CAC, these are a little bit funky to interpret. On the horizontal axis is different willingness to pay thresholds, right? Because depending on what we assume the willingness to pay threshold is, we might get a different answer. And on the vertical axis is the percentage of our 10,000 simulations in which a given strategy was the preferred strategy at a given willingness to pay threshold. Okay, and then each line is one of our strategies. So in this graph, we have two lines. One is the full intervention, which is case management for everybody. And the other one is the control intervention, which is just screening and, sorry, I misspoke. This is meant to be the intervention with case management and then linkage to care for people who are hep C mono-infected. And this is the control, right, where we're just going to educate and send them on their way. And so we can do this analysis many times, drawing simultaneously from all the various different model parameters. And we can say at a willingness to pay threshold of $100,000 per QALY, which is sort of where we started, that this black line, which is the intervention, was the cost-effective strategy at a willingness to pay of $100,000 in 60% of the simulations, right? Whereas this one was only in 35% of the simulations. Sorry, and then I missed this like light screen line at the bottom, right? This is our third option, which is just case management for all, I believe, right? And it was cost-effective in far fewer of the simulations. Yeah, I realized, I tried to skip over that when I realized I was getting tongue-tied, right? So let's just generalize this. Strategy A, B, and C, right? We can make this abstract, right? In this analysis, strategy A was cost-effective at a willingness to pay of $100,000 in 60% of the simulations, right? If, however, we're at a far lower willingness to pay, then this strategy B is the cost-effective option in 75% of the simulations, right? And so sometimes what happens with these is that you end up where sometimes these end up where you have one that's really clearly the cost-effective option in more than 90% of the simulations at all willingness to pay thresholds. So that's helpful. That's a very robust finding. Other times, there'll be two strategies that are 51-49 at a willingness to pay of 100,000, right? That's harder to interpret. Sometimes what we find is we'll have 2 or 3 strategies that are mixed in there and they're all equally likely, but they're all far more likely than whatever it is that to be the cost-effective option than what we're doing now. Right, and so then we'll say, look, like it's not certain. Should you be doing a rapid-based test or a serum test? 50-50, but clearly both provide more value than what we're doing now, which is no testing. Right, so it helps to give a sense of how robust this is and how much the uncertainty is really impacting the findings. Okay, so in summary, cost effectiveness is investigation of value for money. Right? It is not about saving money. It's not about finding things that are cheap, because cost-effective does not equal cheap. Cost-effective also does not equal death panel. Right? The goal of cost-effectiveness is not death panel. It's to provide maximum health benefits. It's just recognizing that at some point the money is going to run out, and when that happens, someone's getting nothing, which is effectively the death panel. So we're going to try to explicitly figure out how we can maximize our outcomes. Right? And so there again, the goal of cost effectiveness is to maximize public health benefits. Cost effectiveness ratios must be incremental. Remember the 6-stool guaiac card example, right? That's critically important. It's important to consider the alternatives that are being compared, right? And that the opportunity cost is a central concept of all cost effectiveness research, and I would argue all of economics, right? You have to do something, and doing nothing is still doing something. Right? Because just sitting on your hands and doing nothing means you're just going to use all the money for whatever it is we're using it for now, which might be appropriate. I have no idea. But it's not nothing. Right? You don't have an option of parking it into zero. Right? Because even if you did that, right, if you parked into zero, you could have been doing something else, and that's an opportunity cost too. Right? So we always have to be doing something. The decision must be made. And if you can break, that's my last slide. I think that if you bring that concept of value into your reading of the cost effectiveness literature, that's where you're going to get the most out of it. Right? I'll say it one last time. It's not about saving money, and it's not about the cost per se. It's about value. Okay, thanks. So the question was, we talked about sort of total cost and incremental cost. And how do you integrate those two things, and which one is important for decision making, which is a great question. I want to make sure that's really clear. So what I showed that slide, what I was trying to show is that actually for the decision making, the cost effectiveness person would argue that it's not about the total cost. Right? This is sort of the distinction between cost effectiveness and budgetary impact in some level. Right? We're less, from a cost effectiveness perspective, we're less interested in the total cost. It's all about the incremental cost. Right? That's what we use to make the ICER. That's what we use, and only that, to say something is or is not cost effective. The problem is you're thinking like a real world person who wants to balance a budget, and there, obviously, the total cost is really important. And so I don't have a brilliant way to integrate those things. Like that is one of the sort of existential struggles of doing cost effectiveness work, and why people get frustrated when you can show something is cost effective and yet still it doesn't happen. Hep C treatment is a beautiful example. It provides really good economic value when you measure it by ICERS in just about everybody in every way you look and in every paper, and yet still we have treatment restrictions. And the reason is because the total cost is really high, even though the marginal cost and the marginal benefits are reasonable. Right? We don't say where the money comes from. In fact, I actually had that explicitly as a bullet point. It's not about where the money comes from. That's the world of politics. Our goal is just to say, this is how much you're going to spend to get a QALY, to inform that discussion. And then you might be right? If most of the benefit is in the healthcare sector, maybe it does make sense to put those costs into the healthcare sector. If most of the benefit is in the labor market, maybe it makes sense to put those costs somewhere else. But that's the realm of politics, not the science, which generally, I mean, I will say this, I hate it when people say that. I think if you're engaged with this type of research, you're sort of saying you want to be involved with both. However, that's good, but they're slightly different hats. Right? And that's what's fun about doing this work. Some days are very sort of nerdy, mathy, economic meetings about dollars and incremental assumptions and the modeling stuff and probability theory. And other days are much more sort of perspective level, like advocacy for policy in DC or something like that. And both are sort of flip sides of the same coin, but they are different sides. Simulation models are useful for cost effectiveness work, but there are many people, who do simulation models for things that have absolutely nothing to do with cost effectiveness. So yes, if your simulation model does a good job of modeling the downstream transmission, it is possible to include all of those benefits and all of those costs in a cost effectiveness analysis. And so we're working on that now. Some others do it, right? And then there's all kinds of debates in the literature about what's the best modeling approach and all of that, but that's a different topic.